Good morning. It's my pleasure to be able to be a part of this nourishment series. Can everybody hear me okay? I'm going to look for any yeses in the boxes, but I'm going to keep talking as if that's all happening. So why did I choose treatment expectation management for this particular day? And I think the reason why is because this is a big deal. It's a big deal for pretty much everybody who's involved in a resident coming to residential care for treatment. Whether it's the referent who is the one making the referral, whether it's the client themselves, whether it's their family members or loved ones. Everybody has some level of expectation as to what is going to happen with their loved one away at treatment for X amount of days. So I think that addressing those expectations up front and setting the tone for what families, loved ones, clients can expect is really important. It's a piece that I personally, as a primary therapist here at Sierra Tucson, spend a lot of time speaking to and managing with each individual, because those expectations differ based on that individual's level of experience in treatment, whether it's their first time, whether they've tried multiple facilities. Everybody has some perception as to what's going to happen or how it should happen. And so I'm not sure with the people who are on this call what your experience is with residential treatment or Sierra Tucson as a whole, but I'm going to speak kind of generally and specifically at different times. And so feel free to ask any questions. I will also keep an eye on those and work those into this morning's presentation. What I tell my clients when I meet them for the first time is what I want to know is, are they here privately paying, or are they here with insurance benefits? It's really important for me when I establish rapport with them to be as transparent as possible. What I tell them early on is that the average length of stay for an insurance-based resident who seeks this level of care is approximately 10 to 14 days. This always shocks everybody. Again, it's an average, it's a mean. I tell them we have an entire department that works on keeping them in treatment so long as they continue to meet clinical necessity. And I explain to them what that is. I tell them this, especially if they are using insurance, because at any time, their insurance could decide that they're no longer meeting clinical necessity and they may recommend a different level of care. When residents get here, they're expecting to, most of the time, spend 30 days at Sierra Tucson and then go home and suddenly they're cured and they have all the answers. This is also a big hope and expectation of the people in their lives. This makes it very difficult to talk about next steps after residential care. So I decide to start those conversations early on in treatment. And again, usually in that first session, to talk about kind of normalizing what that's going to be like. In my group room, I have on my board kind of a how to do Sierra Tucson, and the expectation is that folks are going to be here for 30 days. That is what the program is based off of, and that is the way that we manage their care while they're here. I explain to them that they have different groups, classes, modalities, integratives that start to weave in the longer that they're here. And I explain to them if they come here for trauma specifically, and they're like, I want to do my EMDR, I want to do SE, like, I've been here 2 days, why aren't these things happening? That's an expectation. And so I explained to them that it wouldn't be in their best interest because they're still orienting to this environment. And while they're orienting, we're not going to throw them into a pretty intense, possibly intense session to talk about their deepest trauma at their basic core. And so we want them to spend that first week getting oriented. And that is what I tell them. You've left your life, you've left everything you know, you've left your job, you've left your family, you left your pets, you left all of your coping strategies that you were using, and here you are in a new environment with 100+ people, and that's just the residents, with an entire treatment team that you're just getting to know, in a process group that you are with, 8 or 9 other people, and you don't know them from anybody. It's incredibly anxiety producing. So I try to normalize and ask them to be really gentle with themselves in this first week. It's a new environment, it's a big campus, there's a lot of groups, there's a lot of classes, there's a lot of facilitators. And so, it takes time to settle in. And the way that people were managing their lives before wasn't really working, and they don't exactly have access to those skills right now. So people are typically very anxious, very scared, and really wanting to get to work. So the first week is about orientation. The second week, I tell them, is about awareness. This is the time where you've settled in and you are going to start to become aware, hopefully, of why you came here. Most people think they come to treatment because they have an addiction that they're trying to manage. They've had some infidelities. They've been raging. They're overly stressed. They can't get out of bed. They're naming the very specific coping strategies that have not been working for them anymore. And so there's this whole list of maladaptive behaviors, both process addictions, substance addictions, mood issues, suicidal ideation, countless others. And they know this is why they came, to get help. And yes, that's true. And all of that starts to get addressed in those first couple of weeks. And we utilize a lot of different evidence-based practices like CBT or DBT, cognitive behavioral therapy, dialectical behavioral therapy. We have them in various relapse prevention groups, all kinds of, standard treatment groups and classes. We have them introduce themselves to their process group. They meet their physician, they meet their therapist, and they kind of get going. And so we can address those symptoms early on. And what I tell them is that's great. You need to be able to do that stuff, but there's more to it. And you're not ready to quite go there in that first, 7 to 10 days, which is a really important piece of information. On my board, I have 7 to 10 days gets a little slippery. What we notice is that it's in that little window of time that people think about leaving treatment. They think about leaving treatment because either they're going through withdrawal, or they're having grief, they're having fear, their anxiety is getting higher. They're starting to really dip into their feelings. And that can be a very uncomfortable place for most people. And so let's try to normalize that. Let's pay attention to it. Let's bring it to their attention. So I tell them in that time period, around 7 to 10 days, if you're thinking about leaving, it's probably going to happen right there. You're far enough away from your life as you knew it, and you're a week and a half into your treatment experience, and talking about things and feeling things and listening to others, which is bringing up other things and experiences. And so people tend to get a little squirrely. So what are the awarenesses? So that's week 2. What's happening? How are you coping? How are you not coping? Week 3, I tell them, is about acceptance. We've been sitting in a lot of awareness. So how do we move to a place of acceptance? And what does that typically look like? So a pre-COVID world, Family Week would occur here at week 3, where people would have invited loved ones to come in and be a part of their treatment. This is really important for the family's expectations that they're going to be included. Post-COVID, we have a lot of conversations with the family members as their treatment team. And I personally try to have a call weekly with somebody in my resident support system outside of here to bring the external into the internal experience, which is happening on campus. So week 3 is really about acceptance and hearing things and feeling things that might be really difficult. And so 4th, and if there's a 5th week, really focuses on action. And what I tell people is from the very beginning, as we're getting to know each other, that the treatment team will be making a recommendation for continuing care and aftercare. It's a vital part of the process, which most of the time residents are not expecting. It's hard enough for people to think about leaving their life for 30 days, let alone thinking about leaving their life for an additional 30 days or longer, depending upon the recommendation. And so it's a very difficult conversation, and it's really important to be transparent about it and explain the reasons why, and citing various literature that, you know, the first 120 days is really a vital piece and time period to be able to create change. It's enough time to allow medications, any changes to medications to start to take place, to be able to look at some of that shame that might exist. So in those first 2 weeks, we talk about how we can address a lot of the obvious symptoms that people think they come to treatment for. And that's great, because if they're insurance dominant and they're dependent on that, then it's possible that at that 2-week mark, we could start to see some pushback from managed care insurance companies. And so we need to get them sober. We need to get them kind of out of their routine and into a new routine. We're focusing on sleep and what have you. And so behind all the external symptoms that everyone can point at is typically some level of anxiety and or depression. And so me working with their treatment team and helping address those issues and starting new medications and doing some of the new therapies, introducing mindfulness and meditation and other trauma-informed modalities, getting them into yoga, getting them outside and walking around. The desert is a remarkable place, and most people haven't spent a lot of time here, so they find it quite interesting. And so it's a good reason to get up and get out of bed and go take a mindfulness walk with some of our adventure therapy team. So we start to address the behaviors, we start to address some of the organic symptoms. We try new medications in those first few weeks as they are learning to become aware of what's happening. So it's really a simultaneous event in their time here. So behind any anxiety and depression is typically some level of shame, possibly, not always, but most of the time, there's some level of shame. There's a considerable level of fear, usually. And behind that is typically some level of trauma. I would say 99% of the people who come through have a history of trauma, whether it's in childhood or vocational or events in their lives as adults or children. So these things didn't come out of nowhere. And so as residents are engaging in the different modalities, their awarenesses are increasing, they're starting to get a better sense of things, they're starting to really delve into their feelings, and it makes sense that they might feel a little bit worse before they feel better, which is something else that's really important to normalize. So to manage that treatment expectation. I use the internal family systems model a lot to look at the different, in that model, Richard Schwartz talks about our firefighter short-term relief from any painful feelings and fears and thoughts. And then he talks about long-term strategies to manage that and those manager parts. And so we look at all of those parts to help to kind of normalize and strategize a new way of dealing with feelings of fear, shame, loneliness, not good enough, anger, all of the core feelings that people really struggle with outside of being happy, which oftentimes is not unusual that people can't tolerate happiness either. So normalizing that and explaining kind of how the system is set up and how these tracks are derived and why can go a really long way to reducing people's anxiety about getting the care that they need, which is ultimately a big issue when people are coming into this environment, possibly for the first time or even second or third times. So knowing that there will be more care, it takes a little bit of time for our treatment team to get to understand a resident. And so there's where having communications with the referent, whether it's a therapist or psychiatrist or psychologist or a physician, anyone who's been working with this client, they have a lot more rich information about what this individual's been through as they have a longer relationship with them. So it's really great collateral information to be able to understand where somebody's coming from. And again, doing so transparently, either with the resident or bringing the resident into those conversations. So those individuals who have referred their loved ones or their clients or patients here also have expectations and hopes. And I think that's ultimately what expectations are hopes that this is going to work, that something's going to change, that things are going to be different. And the process is incredibly intense and difficult to explain to people who haven't really been through it. Hence the family expectations. So family members by far and loved ones are typically the most concerned about the well-being of the clients and the residents. They are also hanging on to a hope that something's going to change, things are going to be different. Some have set expectations or ultimatums. Some have already checked out. A lot of them are already traumatized themselves in having dealt with the individual who's come to treatment. So really being able to convey to loved ones, friends, and family that they also have resources available to them. Acadia Healthcare, our umbrella company, has a very good system of care to help connect people in their communities to providers. And so through those treatment placement specialists, family members and loved ones can also get support outside of their loved one being here in treatment. And so I always will tell people, one person cannot heal a family system. And so everyone has their role and part. And so when family members are open to and willing to engage in their own work or their own therapeutic journey, things can really shift for everybody involved. So that's one of the conversations that I might often have up front with family members and loved ones. I'll also explain all of what I've just shared so that they can also understand kind of the progression of the treatment experience. We will also start to involve them in continuing care planning and aftercare planning. And so oftentimes what will happen is family members have one set of expectations and residents have a different set of expectations. So it's kind of a finessed conversation about next steps, aftercare, continuing care, the reasons why, helping a resident understand that they're more vulnerable and raw than they can imagine. And if they haven't been through this experience, they don't necessarily understand that piece. And so having that continuing care aftercare conversation with all the members of their treatment team at different times is really important. So we as a whole have a lot of cross-departmental communications, lots of multidisciplinary team meetings where physicians and providers and integrative specialists and the therapists are all talking about each individual resident so that we could best understand what they need moving forward, and we can each approach that in our own way with the rapport and relationship that we have with the resident. So residents are not leaving here without an understanding of a recommendation for next steps, and that's pivotal to their success when they leave this level of care. So there are a lot of barriers that people might present as to why they cannot go on to the next level of care. And so again, normalizing that 30-day experience and saying, listen, we can just touch the tip of the iceberg with all the things that you've been dealing with or feeling or not feeling for the past 10, 20, 30, 40, 50 years. And 30 days is really an arbitrary number. Our goal at this level of care is to highlight what it is what I say to my residents. And the it is all the various aspects of their emotional disease and their struggles and their maladaptive coping strategies. And so we can just kind of open that box and we can address some of those pieces, but we can't address all those pieces in this short amount of time. So that is a really pivotal piece in being able to promote and encourage people to consider the next step, whether that's stepping down to a boarded partial hospitalization program, whether that's going on to an intensive outpatient program, either for addiction, mood, co-occurring trauma, and kind of other outpatient resources. And so really encouraging people to consider how incredibly vulnerable they are after having done deep dive work, emotional work. I tell them it's like emotional surgery, and that there's a recovery period, and to really invest in that recovery period, because if you don't, then it's likely you're going to need more emotional surgery. And so these are difficult conversations because they really hit at somebody's hopes and expectations. And it was, most of the time, it's incredibly difficult for people to leave their lives and come to a place like Sierra Tucson for X amount of time. And it's difficult work, it's not pleasant, but there's a lot of reward and relief at the end of the day. And so I'm going to answer just a couple of questions, and then I'm going to be open to more questions. And the first thing that I'm reading about is, do people usually normalize their treatment experience in that first week? And I would say it depends on the individual. Some people can really lean in. They might be highly motivated, either internally or externally. Oftentimes in group, they will, the facilitators might ask, general questions and ask their peers, what was it like to be you on your first couple days in residential treatment? And can you go back and share that experience, strength, and hope with this new individual who is pretty overwhelmed after they've introduced themselves? And so the residents themselves can really normalize that experience. And I find that when somebody gets that message from multiple different angles, and they feel more comfortable, at least with the people in their core group, they can start to really lean in and normalize by the end of that first week. And so it's a difficult piece. And there's another question about what happens if people intentionally only come for a short period of stay. So it's not unusual that we'll have people who admit for maybe 2 weeks instead of 4. And that's incredibly challenging because it's not enough time to really dive in and start to do the deeper emotional growth work around shame and trauma and managing, symptoms of anxiety and depression or anhedonia. And so it's tough. And what I'll tell to people to manage that expectation of I was willing to take 2 weeks out of my life and this has to work is it's not going to work. All it's going to do is show you some things right when you need to be able to lean into them and you're going to get ready to leave. And so intentionally so, keeping the interventions safe is really important. And again, not knowing if they're going to invest in that back end continuing care piece. Typically, if someone comes for a short period of time, there's usually, I say usually, a built-in barrier for them that they're returning to work, or they have a trip planned, or they're moving, or there's some external piece that's driving their stay, and it's not based on any kind of clinical necessity. And so a 2-week stay is at times, less helpful than coming and staying for an entire period of time. And so normalizing that and setting those expectations and really talking about continuing care from the very first conversation, that if you're only going to be here for a short period of time, then those next steps are going to be vitally important. And so I think that one of the things that can be really difficult and comes up often, there's a question about this, a very tough situation to normalize and how to succeed, comes when we have young people in treatment whose caregivers or parents or loved ones are possibly the financial backing for that experience, that residential experience. And you're bringing them into conversations and everybody's talking, and the young individual does not want to go on to the next level of care or what's being recommended. So that's probably one of the toughest scenarios in family dynamics and interpersonal relationships that's difficult to manage. That young people, one of the things we typically work on is them having agency in their life, which is developmentally appropriate depending on the circumstances, which obviously is individualized, but allowing them to be part of the process and to assert their own agency and desires into next steps. Whereas oftentimes parents or loved ones can be fairly influential, both positively and not so positively, and oftentimes maybe demanding or insistent. And it's just a tough scenario all around. Oftentimes young people are financially dependent on their family, and feel like they don't have another choice but to do what's being asked of them. And that can create a lot of difficult dynamics to manage. So it's important that people have agency in their own care and their next steps. And so when people are, really struggling with this concept that there's more treatment after treatment, that emotional surgery reference is still vitally important. You can reframe it in any kind of physical way that you want, of managing diabetes or breaking a leg and needing to do physical therapy. For some reason, people seem to be able to manage metaphorically these other physical health scenarios in order to apply them to their emotional and mental health. And so prioritizing that is equally as important. So being able to have emotional hygiene in addition to your standard hygiene on a daily basis is pivotal to any kind of treatment success or long-term sobriety or recovery. So I'm hoping that these things have been the things that we talked about and the things that I brought up might help in setting some of those expectations on the front end. It starts with the suggestion that someone need to go to treatment or consider going to treatment, whether that's from family or professionals. It starts in the admissions process. It continues on through the treatment process and kind of gets weaved into every conversation or group environment to help people prioritize their life over the potential perceived cost of care. So a lot of the barriers for treatment really can be money or time or feeling very like there's a lot of responsibilities that people need to get back to. And ultimately, at the end of the day, what I will say to individuals is, I want you to get back to those things too. And I'm asking you to invest in yourself to make sure that you can get there. It's an ongoing organic conversation, and it's a difficult conversation. And so being able to kind of lay out the treatment experience and address and normalize what those concerns typically can be, and really identifying when things start to get a little slippery in that first to second week can really reduce a lot of people's anxiety and help them to get a better sense of what can be done in a short period of time. So thank you so much. This has been really enjoyable experience. I'm hoping that anything that I have shared today might help you in your practice and your lives. And I am grateful to be working here at CR Tucson. Thank you for your attendance. It means a lot to us, and enjoy the rest of your day.